You are in for a treat today. Today, I am playing one of our most listened to episodes all about apraxia. When I was thinking of covering this topic during season 1, I thought we have to have the absolute expert on. So Dr. Edythe Strand came on to the podcast to discuss how to help students with apraxia of speech. She is such a kind and caring researcher, clinician. I actually ran into her at a talk on speech motor chaining at ASHA 2024 in Seattle, Washington. And she remembered me and said, "Oh my goodness, I loved our podcast episode. That was the first podcast that she had been on." So as a speech therapist, you may feel comfortable with apraxia. You may want to learn more. And as a BCBA, you may not know a whole lot about apraxia. It's definitely not something that we cover. And so we're going to talk all about what is it exactly and how specific our skill set needs to be to ethically and competently support a student with apraxia. I hope that you love the reprise of this episode, one of our most listened to, episode 44 with Dr. Edythe Strand.
You're listening to Autism Outreach Podcast, a podcast full of ready-to-use strategies to help those with autism strengthen their communication skills. Here's your host, Rose Griffin of ABA Speech, a speech therapist and board-certified behavior analyst who shares tips you can use in your next therapy session.
All right. Thanks so much for joining us on episode 44 of the Autism Outreach Podcast. And we have a stellar episode for you today. I am beyond excited. We have with us Dr. Edythe Strand. Thanks so much for joining us.
Thank you for having me. I'm looking forward to our conversation.
It's amazing to have you on. This has been so cool to talk with you. We did a little bit of a meeting last week because we hadn't met exactly yet virtually. And I found out about you and your work really when you were offering this, I think it was a 10-hour, maybe free course. We had talked about it a little bit. And it was just really just amazing information. My company is an ASHA-approved CE provider, so I really appreciate people that put together really great courses like you had offered. And it was just so informative. And I was like, wow, this is great information. So I think that's when you first popped into my radar. But, I get a lot of questions from parents, and there's just so much information out there about apraxia. I'm so excited to talk with you about that tonight and just share that information, because what we had kind of talked about before is, I've been a practicing clinician 20 years and I never had a whole course on apraxia or probably anything that you're going to talk about. So I'm a little selfish in the fact that I'm definitely a lifelong learner. And I like to have a podcast because I like to have people on that I like to learn from. And I know my listeners are going to be so excited. But you've just had such an amazing career and have contributed so much to the field. But can you tell people, if they're not familiar with your work, can you tell us about you and your journey in the field?
Sure. I'll try to make it as brief as I can. I'm getting up there now, so it's kind of been a long time. I got my master's degree in 1973, so I'm almost to 50 years. So I actually practiced in the public schools and private practice for 9 years before I went back and did my doctorate, and then was at the University of Vermont and the University of Washington as a professor, but continued to always be in the clinic, seeing kids, doing clinical research, I did a lot of work in my early career actually with adult motor speech disorders, and then again at Mayo. So while I was at the University of Washington, I was recruited, luckily, amazingly, to the Mayo Clinic, where medical speech pathology actually began. And I was working there with my colleague, Joe Duffy, and later with Heather Clark. And it was just a wonderful opportunity. We saw patients all day, every day. Wow. So I'd like your listeners to know I'm their colleague. I'm a peer. I'm a clinician first. Yeah. We did come in often on the weekends and evenings to do research and writing. But it was a wonderful clinical laboratory at Mayo because we saw so many children and adults with motor speech disorders due to neurologic problems. So I've been so fortunate to be a clinician, a researcher, a professor. And now in retirement, I'm doing a lot of teaching and consulting. And it's a way to keep contributing, which feels really important to me. I only retired because my daughter had a child, and I was finally a nana.
Aww.
And so I moved back to Seattle to be with my grandchildren. But I have the opportunity to travel all over the United States, and in fact, much of Europe and Scandinavia and other places. That it's just been an amazing opportunity to meet speech pathologists, clinicians all over, and all of them talking like you did about the fact they had very little training in pediatric motor speech disorders in their university settings. So I feel like, this fills a void. And so that's what I'm doing now.
Wow. I'm #life goals. Those are some of my life goals there. I'm doing them on a small scale. I am a speech therapist in a school 3 days a week. And then I have my own business, ABA Speech. We're an ASHA approved CE provider. And, we do courses and, but I do some consultations and coaching. And I do a lot of things abroad too, with my BCBA licensure. It's a little bit easier, but it's really amazing. And I did an international consult this week with a family, and I love being able to help people who just don't have the resources, in their geographic area. Like, I love being able to just virtually connect with people. And it does feel so good to be able to help in that very specific way when you specialize in something. It's so cool. I love that you're doing all those things. I love all those things too. So I knew we were lucky. Yes, that's awesome. So today, I know we're going to talk about quite a few things, and we're going to start really basic. So if you're listening, we do have some listeners that are parents, and then we also have speech therapists, and then we also have some people who are just special education professionals. So I think this information will be really, really great. So just kind of starting out with the basics here, can you tell us a little bit about the characteristics of apraxia?
I will. I'll be happy to. First of all, I think it's important to remember that apraxia is just a label for a speech sound disorder. When I often am teaching or asked to speak somewhere or consult, there's this misconception that it's a medical diagnosis. Mm-hmm. And it's really not, any more than adult apraxia is. The stroke or whatever caused it is the medical diagnosis, and apraxia is a type of speech disorder. So childhood apraxia of speech is a type of disorder. It does have particular characteristics that help us with that differential diagnosis. The trouble is there's many, many lists of these characteristics, and they're all present in children with apraxia of speech. The trouble is some of them are clearly present, but not necessarily discriminative. Mm-hmm. Because those characteristics are common in all types of speech sound disorders. So, those would be things like a limited consonant and vowel repertoire, or the use of simple syllable shapes, or frequent omission of sounds, those kinds of things. Poor intelligibility, that can be the result of any speech sound disorder if it's severe. The characteristics, though, that are more likely to be discriminative relate to the movement characteristics that occur because of the difficulty with planning and programming movement gestures. So in these kids, you'll see awkward movement. We have to, instead of, it's kind of a paradigmatic shift, because as trained speech pathologists, we're so used to thinking at the phoneme level, right? If we're thinking about articulation. Mm-hmm. And in apraxia of speech, in both assessment and treatment, we're looking at the movement. Movements are sequential. We don't say at, we go at. And so, when I'm teaching, I'm always taking my voice out and say, you have to watch the movement, boy, look at the movement, because that's what you're training. But it's also true in assessment. So you look for a characteristic where there's that awkward movement through the movement transition. You'll see groping and trial and error behavior. Sometimes the groping is silent. Sometimes it's accompanied with voice. You often don't see that, however, in their spontaneous utterances, but you will see it when you're eliciting speech, like in a motor speech exam. Oh. If they're trying something they don't, because when they're just talking, especially if they're more severe, they're going to say what they can say. Right. But if they're trying a movement pattern that they don't yet have, then you'll see that groping. Vowel distortions are really common in children with apraxia of speech. inconsistent voicing errors and inconsistent manner errors. So if you expect a voice sound and you think, was that voiced or unvoiced? That's a sign of apraxia because of the mistiming of the categorical perception, typically. Or a blending of manner where you hear a sound that isn't really an M, but it isn't really a B either. So those are distorted sounds that are more characteristic of apraxia of speech. They're not just substitutions. Another thing we see a lot in apraxia is an intrusive schwa. So instead of saying bed, they might say beda, where they put that little at the end. And that you rarely see in phonologic impairment, but it's typical in childhood apraxia of speech. It can also be in the middle of a word, like instead of bike, they might go bayak. Bayak. So that's an intrusive schwa. And then one thing, and I want to finish with this because it's sometimes misunderstood. Inconsistency across repeated productions of a word is a big hallmark, and everyone talks about it. And at Mayo, we would get so many kids with inconsistent errors, and so just for that reason, they were considered apraxic. And that doesn't always work that way because kids with some kinds of speech sound disorders can be very inconsistent. Also, children with phonologic impairment, as they get into therapy and they're starting to generalize, they're inconsistent, they're self-correcting, that's common, but it's not a sign of apraxia in that child. Also, kids with apraxia who are very severe are going to be consistent because they can't do very much.
Right.
So we look at inconsistency really in the context of repeated word production, like in a motor speech exam. Okay. And if you ask them to say, tell me boy, and then they distort the vowel and say it again, and this time they distort the consonant and the vowel, and the next time they might be closer, that is the kind of inconsistency we see in apraxia. So, there's lots of lists out there, but you have to think about the context that you're paying attention to these characteristics about, and you have to think about, is this discriminative? Or is this something I might hear in a number of speech sound disorders? I think the other thing we really emphasize is that you also want to look for these characteristics across tasks. Never do it never say, well, I talked with the child and heard these characteristics. Conversation is one task. You might want to do picture description, conversation, story retell, and certainly a motor speech exam.
Right. Oh, that's good to know. And, an observation, would you agree, like observation too, if you can see the child? I'm just thinking as a school-based therapist, I always try to observe just to see, because it's so different in the different environments, right? Like
absolutely.
Me in the therapy room with a student versus them talking to their friends at lunch, like lunch, gym, that's like a lot of good information for me because kids seem to, it's unstructured, right? Okay. That's right. That's really good information. I guess what I really struggle with too, like the information you're sharing is so amazing and so specific. And I think too, to people that, probably haven't maybe heard this information or haven't taken a course in this. So I think there are probably a lot of speech therapists that are probably like really nervous, like, oh my goodness, what if I've been treating a student wrong? What if I haven't been using the right treatment? What happens if we don't use specific treatments towards apraxia for a student? Like, let's say that we haven't taken a course on this and we're just not as in tune with this. Kind of what are the pitfalls, I guess, if we're not treating it correctly, I
can speak to that. But first, let me just assure any SLP out there who's feeling that way. We have all experienced that with patients, and both adults and children. I certainly have. When I started in my hospital work, to be honest, I had no idea what I was doing. I had to do a lot of continuing ed. I hadn't had a good neuro background at that point in time. I think that's the whole reason I did the doctorate.
Right.
But because I was so chagrined. And there were times where I would drive home in tears because I felt like I wasn't helping that stroke patient who had that severe apraxia. It will happen in our career. What we do is hard. So the first thing I want to say is don't beat yourself up. What you're doing, though, is listening to a podcast about this topic. You're putting yourself out there to learn more. And that's terrific. And there are lots of ways to get more information about apraxia that I will share. I forgot to ask you about this, Rose, but I'm going to send you.
Oh, yeah.
I don't know if you have a place to post all these.
Show notes. Yeah, absolutely.
Both video kind of courses that are free as well as articles that will meet different needs. But
great.
But let's say you don't know what you're doing. And this happened a lot at Mayo, where we would get kids with severe apraxia who had been in therapy for a few years and still had no words. This does happen.
Mm-hmm.
Well, several things can happen, and it all depends on the severity. If they're real severe and you're doing a language-based, child-centered or child-driven approach, very little change in motor speech will likely occur. Mm-hmm. On the other hand, if you're taking an articulation approach, they might, and they're not real severe, they will make progress. It's just going to take a lot longer if you don't implement principles of motor learning. That's probably all that'll happen. On the other hand, if the child's quite severe, they could make very little progress or no progress. But at that point, I think any therapist is going to ask for a second opinion, reach out to their village, to their people, and get some answers. It does make a difference. We saw that over and over again at Mayo, where kids came in with very little speech, and once we switched to a motor approach, increased the frequency of therapy, increased the number of practice trials per session. And implemented a number of principles of motor learning, which I'm going to give you references for, that you can access easily. I mean, there's big articles I could give you, but I mean, there's some that we've written that are just clinical based. This is what you can do tomorrow, that kind of thing, which I think is so important. So, it depends on the severity of the child, but it does make a difference if you aren't taking this motor approach.
Yeah, no, that's really good to know. And I know I had on a speech therapist recently who also has a daughter who has apraxia, and she just really immersed herself in apraxia. Those are the only clients that she sees now. I think her daughter's in middle school now because she really didn't have a background in it, and she couldn't believe that she hadn't learned all this. And so she really dug deep, and that's what she specializes in now. So it's cool because she just felt like, how did I not know this? And so she really kind of dug in. So I know that we always have to start with an assessment. That's obviously most important. We've talked about that a little bit, but can you talk to us, like, what is a dynamic assessment? What does that consist of?
Right. Well, dynamic assessment is different than a lot of the assessments we do in speech pathology, in that it involves actual cueing and then scoring responses based on the response to that cueing, versus static assessment. Let's say an example of an artic test, maybe a Goldman-Fristow, or a language test, maybe you're doing an OWLS, or whatever you're doing. Typically, there's a picture or a question, and they respond once, and we note the response. So that's static assessment, and that's a lot of what we do. Mm-hmm. Dynamic assessment was being done quite a bit in language disorders and a little bit in phonology. And I started thinking about that, and I was thinking about what I do in assessment just naturally. And I realized this is dynamic assessment. Why don't we have a tool for that? Right. And so over a number of years, I'm embarrassed to say like 10 years, I developed this dynamic assessment called the DEMS, Dynamic Evaluation of Motor Speech Skill. But it's just one, I mean, a person doesn't have to like get the DEMS, because it just means you're doing a motor speech exam. So for a very severe child, you'd have some number of consonant vowel consonant, reduplicated syllables, CVC, just different length and phonetic complexity, these little subgroups. You'd say it, they'd say it. If it's not correct, you would cue it. So maybe first you just do a little gestural cue if they can't get good lip closure. Me. Or if, for those that are listening, I know some of you are listening rather than
yeah. No, that's good.
Gesture. And if they still don't get it, then we might do a little tactile cue, where we just use our lip, bring their lips together. We want to work hard to increase proprioception. So we might say, feel that, look what I'm doing, do what I do. Don't let go when I take my hand away. Don't let go.
Mm-hmm.
So you're increasing the proprioceptive ability of the child. They're getting the visual cues, very important for them to watch you. We've learned that through our research that if they're watching our face,
Mm-hmm.
they're going to do a lot better than if they're looking at a picture. So that's a treatment answer, sorry, but even in assessment, we don't use any pictures. We want
Okay.
them watching us.
Oh, that's interesting. So I haven't given this assessment because I kind of work with a different population, but I find this extremely fascinating. So with the dynamic, so with this assessment, are you trying different cues? Is it like a hierarchy where you're trying a cue and then you're saying like, was that better? Or, I mean, is that kind of how it is?
Exactly. We usually do a hierarchy where we start with just the gestural cue, or they're always doing the visual cue. And so we might slow it first with the gestural cue. Then if we have to, we'll add a tactile cue. If we can't get anywhere, then we might go all the way back to our old toolkit of speech pathology and we do phonetic placement for a while. If they really can't get the tongue to the alveolar ridge for a T, or if they're having trouble with lip closure. And then we go through the rest of the hierarchy of cueing. Now, in a formal standard dynamic assessment like the DEMS, you have this hierarchy of cues, but you only give them 6 tries, or you'd never get through it. Although we've got it to the point where even for a severe child, you can do it in about 20 minutes. But and for a child that's more mild to moderate, you can do it in 10 to 15. It's really not that long. It looks long when you look at it, but it's quick to do. So it does involve this cueing, and then you score it based on their responses to that cueing.
Okay. Oh, that's really fascinating. Yeah, really, really. Yeah, I love that it's so specific. So then this obviously would give you then really good information about how to plan your scope and sequence of intervention as far as where you're going to start and how that would look. That's
absolutely, Rose. That's the perfect observation to make. That's just what it does. The benefits of dynamic assessment, besides differential diagnosis, we did research to assess the validity and reliability. How well does this test reliably distinguish groups of kids that are apraxic from the larger group of speech sound disorders? And we showed that it was valid and reliable. So good. That's the differential diagnosis part. But there's more to the benefits of dynamic assessment. One is you get to see what kind of cueing works well for the kids. You know, especially with the autism population, there are some kids that can do the task. Mm-hmm. They're social, they're responsive, they can watch, but they don't like to be touched. Mm-hmm. So tactile cueing isn't so good for them. So you wouldn't do that. But other kids maybe respond better to different kind of cueing. So you learn that in the dynamic assessment. You get a much better idea of severity. For example, you can give 2 kids the Goldman-Fristow, get a standard score of 40, and you know in your clinical heart, one child's going to fly and the other child's going to be in therapy for a while. But you don't have anything to prove that. You know, you don't have anything other than to tell the parent about the severity, other than I've seen 100 kids, or I've seen 1,000 kids. I know your child's going to struggle. On the other hand, in dynamic assessment, the score really does reflect severity. In a way that's very important as you're thinking about prognosis, early treatment targets. Those kinds of things are all really, the dynamic assessment is a huge benefit in those ways.
Yeah, that's really fascinating. And you touched on autism a little bit, but I do get a lot of questions on social media just about apraxia. And it's definitely not an area that I specialize in. And so it is interesting because some of the things, you know, I know that I've worked with students, like I've always worked in a public school. And then before my business got too big, I always worked in these we call them non-public programs, but they're, you know, applied behavior analysis type centers for students who typically have a lot of behavioral barriers. So sometimes like we would try to work on imitation even, but some of this that you're saying, it's so nuanced that I would imagine that maybe not everybody is a candidate for it just because of the prompting. Would that be true, do you think? Or because you do have to have like a level of sitting and, you know, being able to be cued and prompted and things like that.
You bet. There are, I guess you would say, you know, basic requirements to be able to do the dynamic assessment and or the kinds of treatment apraxic children benefit from the most. But we've been successful with 2-year-olds and with very hyper kids by bringing in very quick reinforcers, a lot of novel things, hold my hands, look at me, you know, things that are just constantly changing things around. Now, that's not specific to the autism population. I think with the children on the spectrum, you know, it varies so much. The children that didn't have joint attention yet, because we saw a lot of children, we had a big developmental clinic that we would evaluate children for. And we saw a lot of children with autism. And this isn't my specialty either, in that I don't do research in this area, but I've seen a lot of children. And if they don't have joint attention yet, beyond, you know, if they have any attention, if they can imitate anything, we start, you know. But if they don't yet have joint attention, then they're not then we have to work at, you know, language and cognition and pointing what you want, that kind of stuff. So we, you know, those kids wouldn't be at all appropriate. On the other hand, we've had children who are diagnosed as autistic, who are not high functioning, but they're also able to watch, they're able to imitate. If you organize your therapy and choose your treatment targets within their language capabilities and go slower, and you have to, you know, make adjustments for any attentional problems or repetitive behaviors or unusual things, you can do at least some motor speech training for sure. We did get some children at Mayo who were diagnosed as autistic and apraxic, who were echolalic. And that was kind of an interesting thing to me, because in my mind, they couldn't do a motor speech exam. I mean, they could maybe, because if I said something, they'd said something. But there was no meaning involved. And they were just doing whole scripts from cartoons or scripts from commercials that would just go on. But there was no meaningful communication. And yet they were beautifully articulating these long strings that they were, you know, through this echolalia, and came in with the diagnosis of apraxia. And that confused me a bit, because linguistic link that wasn't working very well. So that was kind of surprising to me.
Yeah. Interesting. Yeah.
So I wouldn't call a child who's really articulates well and echo. Yeah.
Can you tell us a little bit about the diagnosis of CAS in children with autism? Is there a higher prevalence, or is there anything to be noteworthy of that? Because I feel like in the autism world, apraxia is talked about a lot.
It sure is. You know, we don't have real good data on that. But certainly, I saw lots of children with the diagnosis of autism who had no apraxia of speech. But then we saw a group of children who also had a dual diagnosis. It's very difficult to make a generalized statement that CAS occurs more in the autistic population than perhaps in other populations. We know that it occurs in some disorders more frequently than in the general population. For example, galactosemia, veal-cardiofacial syndrome, those have higher incidences of apraxia of speech, but not necessarily autism, but we don't have real good data on that.
Okay. Interesting. Yeah. Because, you know, people just talk about it. I was kind of curious about that. Sure. So can you talk to us a little bit about what is DTTC?
Well, that's a treatment for apraxia of speech. It's dynamic, temporal, and tactile cueing. And again, this is something, just because I was seeing so many of these children. I was, you know, as a clinician, we all do different things. And I knew that the techniques, the phonologic treatments that I knew and had learned weren't working at all. And so I was doing different things, basically influenced by all the work I had done in adult apraxia, where in our college courses, we do get information about treating adult apraxia. So I was trying some of those things. And I read an article years and years ago by Jay Rosenbeck on the 8-step continuum of treatment for apraxia of speech. And it was just a hierarchy, a temporal hierarchy. So you say the word simultaneously with the person with the severe apraxia. So you'd say me, and you do it together until they could do it, say 90% of the time. And you do that for 5 or 6 words. Mm-hmm. And then you'd move to do it after me, me. And then you do it after a delay, me. And then you do it, I forget his whole hierarchy. You do it, have him read a card, you do it some other way. There are like 8 steps. Well, I thought, I'm going to try that with some of these kids that seem to have these same characteristics as the adult with apraxia. Right. And it just didn't work. Okay. And I thought, what is happening? Why won't this work? And it was one of those days where you drive home and you just say, I'm just terrible at this. And, well, I started experimenting, and I thought, these kids have never talked. Adults that have a stroke and apraxia know what speech feels like in their mouth. They have all the language. They've got this experience. These kids don't. So I started changing things where we would do it more dynamically. So I would say they'd do it with me, and then we'd have to cue a lot more. Cue, similar to the dynamic assessment, actually. In fact, the cueing from the dynamic assessment came from the work, from what I discovered as I was developing DTTC. And I didn't start out to develop this treatment.
Yeah, it's fascinating. But you just saw a need. That's what I think is so fascinating. I had Lori Frost on, who is the co-creator of PECS, and I love talking with her because like the business side of me was like, oh, how did it start? And she was a school-based therapist, and Andy Bondi, who is a BCBA, was her school psychologist or something. They were working together and they were working with autistic children, and the students were not verbalizing and they had no other way to really communicate. And it was like, that's how PECS was born. And she was a school-based therapist and she started using it. But I always love that because my mom always said, if there's a problem, you need to have a solution, right? That's how a business is started. And you just had an idea because you wanted to do better for your clients. You wanted to help support them. So I find this fascinating. So
well, not only the trouble is though, you get an idea and then it doesn't work. So you try something else and that works for a while and then it stops again. And then you have that. It took years to develop this. But luckily, while I was working with these kids and doing everything I could to try to make this easier for them, we have a motor speech research meeting every other year, a conference on motor speech. And we always have an outside speaker, a neurologist or somebody, psychologist. And this one year, gosh, this has now been probably 20, 25 years ago. Richard Schmidt, who's a cognitive motor learning researcher, wrote a seminal book in motor learning, came and spoke to us about these principles of motor learning. And it was like, why don't we know this? This is what we're trying to help these kids with, improve their motor skill. Why don't we know these principles? We're certainly not incorporating them into our treatments. So that summer, I remember reading several, just textbooks in that area. And then I started reading the literature. And little by little, I incorporated what seemed appropriate for speech, because all the research in that area had been done in limbs, into DTTC. And so it turned out that the things that seem most important are maximizing the number of practice trials, variability of practice, how you organize your practice. None of these things had gone into my planning of treatment when I was working in phonology or even with the apraxic kids. We'd just bring in a bunch of words. And that's where I learned, too, that they need to watch you because that visual cueing is so important. And that's when I got rid of all the pictures. And then things happened so much faster. So little by little, I learned about this whole other area of research, incorporated it into our work. And many people now who work in the area of motor speech, everybody is well on board with these principles of motor learning. And it's guided a lot of our continued research over the last 20 years, to be honest. So I'll send some references about that as well.
Well, it must have just been fascinating to, because I have this different licensure called a BCBA with applied behavior analysis, but I love to be able to take that science with what I know from speech therapy and kind of put it all in together, because there's less than 450 people in the entire world that have both of those certifications. So I love being able to kind of combine those. And it sounds like you just did that on such an amazing level where, you heard somebody talk. I can't imagine the credentials of people they were having to come talk to you guys about, all the things. And wow, it was so fascinating, but you could see how that could be applied. And then did you just see such a growth and difference in the clients that you were helping to support?
Little by little over the years, absolutely. And so by the time I got to Mayo and we started doing some treatment research, then it became more solidified. And then finally I felt confident enough, literally, I'm sure it was more than 10 years. I felt confident enough to actually write an article describing it, and it's been published a couple of years ago. So I'll put that in the references as well. So DTTC is just a treatment for severe childhood apraxia of speech, where you follow this hierarchy, which is dynamic. So it's similar hierarchy. You do it simultaneously, then direct imitation, then add a delay. And at each of those levels, you're also varying, after they get accurate, you vary prosody. Because, I forgot to say that in characteristics, dysprosody is huge characteristic of apraxia.
Yeah.
They segment often or have equal stress. So instead of saying like bunny, they might go bunny or bunny kind of thing. Lexical stress errors might occur also, but it's more often segmentation. So we built prosodic work in at every level. Mm-hmm. And then when they do so many in a row, at a certain level, then they move to the next. And that's the basic structure of DTTC. But there's so much more to it because you have to organize your practice in a certain way. There's a lot of suggestions about choosing targets, which is huge. You have to be very particular with the severe kids about phonetic shape, movement, the shape of movement, that in a context, the vowel context, all those things. And but all of that is included in the article.
Okay. Interesting. Very interesting. So how is that different? It sounds absolutely fascinating. I love that it's very systematic and there's a lot of structure to it. And I just know this is completely as an aside, but I do have worked with some older students. I had this one student who lived in another country for 10 years, came to the States, started in the schools. I met him in middle school. He had autism. He had no way to communicate. But what was absolutely fascinating about this student, I thought, he's going to use a device, like, we'll try Proloquo or something. And then, but he couldn't point. So he had no point. His point was just no point. So I worked with the OT to shape a point because that's just functional. And then I said, let's start some sign language and we'll also start some verbal imitation targets where I say something, he says something. And what was absolutely fascinating about this student is that when he started talking, he was able to say almost all the sounds that we can say. And it was just like, and I on my small little scale here, like I presented at ASHA about him. I've written an article for ASHA Perspectives about him. It was just like my star student. It was like one of these things you're like, oh my gosh, this is speech therapy. This is absolutely life-changing. But what was so cool is that as he got older and we started putting different words and phrases together on a very small scale, he didn't have apraxia, but I was really analyzing all the different things that I was picking out for him. Like, well, he can say these things. And, for him, like he had autism, it was like, okay, this has to be really functional, right? If he's going to learn 20 new words in a year, because he was older, middle school, high school, they have to be such important words. But it was just amazing for me to see that kind of growth. And it was really cool for me as a clinician because I was really, really analyzing. And sometimes you don't always get to have that kind of student where you get to see that kind of growth or where you're analyzing things at this level. I don't always have the opportunity to do that. As a school-based therapist, it's really hard because there's so many kids who need your support. Yeah. And I was devastated. That child moved last year and I was like, oh my God. I was having a moment. I was very sad. But so I love that idea that, it kind of builds and it's systematic and there's a hierarchy. It's a lot of thinking analytically because these things are so important for these students, especially when they have that severe for, because they may only learn so many words, so they have to be important words, right? I love that.
One of the joys of working at Mayo is the difficult, we had always called them patients who came to Mayo, had pretty serious issues, both the adults and the kids. So we had a whole, also programmatic research, NIH funded big grant on progressive apraxia of speech and primary progressive apraxia of speech. And the last, 6-7 years of my work at Mayo, that was a lot of what I did. And it was interesting to watch as this degenerative process happened. Yeah. And I was also working with these kids where we were seeing this remarkable, improvement. It was interesting juxtaposition, but what we were doing with the apraxic individuals where there was, progression, we would little by little meet their needs as needed by, autism and other kind of functional communication kind of things. Whereas with the kids, they were becoming more verbal. And we're just lucky, aren't we, Rose, that, this profession allows us to contribute something so important. I mean, isn't communication the most important thing in the world as far as I'm concerned? And we get to do that. It's, I think sometimes we just get so bogged down. And I know that public school therapists are my heroes. I only lasted about 2 years in the public schools because, you're so constrained with, you got to do the IEP a certain way. And everyone knows you make a goal in October for next June or something. I mean, come on, that's crazy. But that's, you're sort of forced to do a service delivery model that isn't always the best for speech anyway. It might work better for language and literacy, but it's hard what we do. And sometimes we get so involved in the paperwork and the meetings and that we forget that what we do is so important and we get to do that. And these kids are going to remember what we gave them. I mean, it's huge. And I always want to, when I'm talking to a group of people, I always want to say, don't forget that, you're in a profession. We're just so lucky to do what we do. And
yes.
I always want to say, don't let the IEPs and the meetings you have to go to, don't let it get you down,
Right. Think about the work and try to focus on that. No, I love that because being a speaker, I love it. I'm a guest on a lot of other podcasts. And I remember one time somebody asked me, well, what do you do when you're having a bad day? I mean, and it's not like I've never had a bad day, but I've never had a bad day because of the students. I mean, I've never, ever had a bad day because of the students. It's always something else. You know what I mean? It's like other people, it's the paperwork, it's all of those things. So, I absolutely agree. Like I'm 20 years in and I still really love this job and I love this career. I actually became a speech therapist because my mom was a teacher and she was teaching a career course at her high school. And she gave me a career survey. I was a senior in high school. I never had speech therapy. I didn't know anybody that had really. And it said I should be a speech therapist. So I observed, I observed a family friend and we went everywhere. She worked in a nursing home. We did home health. I went to a school. And that was it. I declared my major and I just never looked back. So I think it's cool.
That is so funny, Rose, because I became a speech therapist because my mother went back to school to get her teaching credential when I was like 12. And she had to take an elective and it was a survey course in communicative disorders. And she brought home the textbook and I'm looking through it and there's all these pictures of kids with cleft palates and there's these people that had strokes. And then there's these people that helped them talk again. And I thought, wow, that's kind of cool. And it was science and service. I mean, it was just, so I wrote speech therapy down for my major, my freshman year of college. I mean, that is such a gift. And I've also never looked back. Our profession allows us to do so much. It was just very lucky.
Yeah, that's so cool. I love that. So DTTC, how is that different? How would that be different than some other treatment approaches that we might hear about for apraxia of speech? I feel like, I'm kind of in this way different space than you. You're in this like researcher space, but I'm in this like Instagram, TikTok, everything social media space. And I feel like sometimes people are, like I definitely read journal articles and I stay in the loop about all that because I make a point to, it means a lot to me to be a lifelong learner. But sometimes people might just be picking up little things here and there. So, how is that different than maybe something that they're just kind of hearing about out and about?
Well, there are a number of ways that DTTC is different, primarily because it's focused more on the severe apraxic children.
Okay.
So it's not that we're ignoring the language needs, and we often work in conjunction with school speech pathologists and sort of like the school speech pathologists do the language and literacy, and we do the speech. But I think the way it varies is that we're very careful to implement these principles of motor learning in very specific ways. Mm-hmm. And I'm not sure that happens in a lot of, treatments that are more artic therapy or phonologically based, mm-hmm. for sure. Mm-hmm. DTTC also utilizes a much smaller set of targets. That's a motor learning principle. We want to bring in some variability, but not so much that we can't get the movement learned, build mm-hmm. that movement. And then the organization of practice is very important. So we'll use a block approach to practice, but we know that if you go more toward random practice, you have better learning. So we start with blocks, we shorten the blocks for each target, and they'll all be at different levels. And then as the child's improving with that target, we'll reduce the length of the block of practice. Instead of 40 or 60 trials, we'll move it down to 10 trials. And then we'll have, only one block a session instead of two, until finally we're just eliciting it spontaneously in response to a question. And then finally it goes to a maintenance phase. So that's all very specified, and that DTTC is different in that respect. I think using this modified block approach to organizing treatment, being very careful in choosing the right number of treatment for the very severe targets for the very severe kids, bringing in this hierarchy of cueing, and bringing in these principles of motor learning. This idea of cueing, while there's a suggested hierarchy, we're also very careful to say you've got to fade these cues as quickly as you can.
Right.
You can't get the gestural cue or slowing, and you have to add a tactile cue, close your jaw a little bit, because they always, move the jaw. They're working hard. They're moving the jaw too much. You have to fade that as soon as you can. If you stay with the tactile cue too much, they become used to it.
Right.
And later learning generalization is harder. So we fade all the cues as quickly as possible.
Oh, that's good. Yeah, that's good to know. So it sounds, how specific it is. Are there specific data sheets that you use when you're using this type of model, or is it just you're using the principles of this DTTC to then do your treatment? I'm just curious because I'm really into data, so I'm just curious.
Well, in most of the clinical work, it's very important to always know what impact you're making. So we did probe testing.
Okay.
And so what we would do in terms of data, we don't take treatment data because we're too busy with this mm-hmm. dynamic method. We've got to, really get these responses. We cue them, we shape the movement, we give them quick rewards. They'll take a little Nerf ball and throw it in a basket after 10 tries. They'll mm-hmm. stand up, put their hands in their head for the next 10, whatever we have to do to keep them with us. As long as they're looking at us, that's fine. And then say every third session, especially if we're seeing in our intensive work, we would have the children always came from a distance. So they'd come to Mayo and stay for a few weeks, and would see them twice a day for half an hour. And boy, that never happens in the real world. And, and we could make so much progress with that intensity of treatment, especially if we built in variability of practice doing that. But we would probe every third session. Okay. So sometimes that was good too. Sometimes it'd be the morning, sometimes it'd be the afternoon. And then we would take the treated probes, what we were treating, we'd take each target and randomly have them repeat them. So it might be boy, boy, me, high, no, whatever. And then we just did it randomly until we got 5 repetitions of each one.
Okay.
And then for each individual target, we would keep track of their score. And we used a multidimensional scoring system. You could do binary, but we did 2 if it was correct, 1 if it was one distortion or one distinctive feature off, one little error, viscosity, and then a 0 if they had more than one little part. It's more defined than that, and then we would add them up. So if they got 2, 2, 2, 1, 0 over those 5, that's 6, 7 out of the 10, right?
Right.
So when they got 8, a score of 8 over 3 probes, sometimes, depending on the child, if I knew they were going to have a lot of good parent if the parents were able to do a lot of the generalization work at home, 8 was fine. If we were working with a family where we knew there wouldn't really be any carryover or homework or any of the things we suggested, we might do 9 or a score of 9 to 10 over 3 sessions before we feel confident. And that allowed us, and then we could just put it in an Excel sheet and chart it out, and we could see where they were doing with each individual item. And then when they reached that criteria, it went out of training and a new item comes in.
Okay. Oh, that's fascinating.
Now, for research, you have to be you have to be more data oriented. You have to have fidelity measurements, you have to have reliability measurements, all that sort of thing. So it's a whole different ballgame there. But for clinical work, because you don't have money and time to do all the things you'd have to do in research, but you can take 5 to 10 minutes every, second or third session, fourth session, if you see them, more often. You have time to do that, and then quickly do the arithmetic. Takes 5 minutes. So, that's doable for a busy clinician.
I can imagine I was wondering with the people coming to you, I can imagine that they probably saw so much growth in their child's communication. I'm sure that you have a lot of stories where, especially if a child was maybe getting not the best treatment or treatment that wasn't frequent enough, and then they come to see you, where parents, do you have a lot of exciting stories like parents were just very excited about the growth of their child's communication in that short duration of time?
Well, we did. And, it's not, was always careful to tell parents that, I've been doing this a long time, so I'm well practiced at it, number one. Number two, we did an intensive program with most of these kids. That's not available in most communities. Mm-hmm. If they're only getting treatment through the public schools, if they get it twice a week, individual, that's like a gold, you're lucky, Right. Mm-hmm. But it isn't enough for these severe kids who really need more practice than that. So I'm careful to tell the parents, it's not me or my colleagues. Right. We have worked hard at this over the years, but it's the intensity and the right approach, or a better, there's no right or wrong, but a motor approach to treating this problem that's made the difference here. So we would work hard with school districts around the country as these kids came. And sometimes we were successful at getting more treatment. Lots of times we weren't. Some states, Medi-Cal or Medicaid, would pay for treatment. Other states, it wouldn't pay at all. And children, some kids have insurance, some kids don't. I mean, it breaks your heart sometimes, to tell you the truth. Just breaks your heart.
Yep. But, yeah, that's cool though, that you're able to, that intensive nature. I love that I'm sure that was really exciting to see that growth. Oh my gosh, I love that. So fascinating. Where can people find it? This has just been such a wealth of information. Where can people find out more about you and your work? I know you said you were going to give me some links, and we can put those in the show notes. So show notes are things that we write up on the abaspeech.org and also on YouTube. And so we can include that. But is there any website or anything?
A lot of people keep asking me for my website. Yes. Well, I'm not good at that kind of thing. I don't do social media. I mean, I lurk on Facebook. Right. But I don't, I got on Twitter when I was in Australia because they did a group thing where people could ask me questions. But I don't tweet. Yeah,
right.
And it's just, I'm busy. I just don't know how I would do it.
Yeah.
I haven't made, and I have never had a website or anything, but I am going to say there is a website. I don't know how you'd find out more about me, but
yeah.
But you can go to a website, childapraxiatreatment.org. And I'll send this link to you. Okay. And that's where you asked about parents and their response to this. There was a gentleman who brought his daughter to Mayo, and we were able to not only come to a diagnosis and explain it. It was a very complicated thing. And I worked with the child's speech pathologist, and she just really improved quickly. And he was frustrated because why don't people know this? And I had to explain that we don't include pediatric motor speech in most of our university programs. So he has a big foundation, and he included childhood apraxia of speech in this foundation and asked me to do these courses. So for a while I did. And then I went and said, this, people come to a 1-day course or a 2-day course and they're hearing all this for the first time. They go back Monday morning, they have, 2 IEP meetings, and they have 6, teen kids in a row. They don't have time to digest or implement it. Mm-hmm. So we put it online, and that's the course you may have seen or heard about. Yeah. But there is, it is through this website, childapraxiatreatment.org, and it's free, and the CEUs are free.
Wow.
And then for some people that are really interested in apraxia, if you do a short reading list, take a pretty simple test, you can apply to come to one of our advanced courses, which, if COVID ever goes away, will be in person again. And these are advanced. You get up and talk about, pretend you're telling a parent what childhood apraxia is.
Right.
How do you interpret this? What do you do? Where you have to really interact. You're not just listening to me talk. Mm-hmm. We're solving problems, very client-based, that kind of thing. So that's one place to go for more information. Plus, I'll send you a lot of references.
Yeah. And I think that's really great. I know we'll have to chat sometime, because I know that I just get so many inquiries from parents about who is really specialized in apraxia of speech. And, parents are just, they're really seeking answers. You know what I mean? They really want somebody that specializes in this. So it would be really cool to be able to know some of the people that have taken your advanced courses. So maybe we can chat about that someday, because I just have so many parents, and, they go to certain places that they heard are good, and then they interview the person, and then they're like, well, that wasn't what I was expecting. And so there's just a lot of savvy parents out there that are doing a lot of research, especially just parents I talk to who have autistic children who are just, really just learning a lot, taking courses online, want to get the best help they can for their child. So it's amazing that people are specializing in this.
Let me give you 2 other things, especially for parents. One is that another different, same parent that I just talked about with a childapraxiatreatment.org website, also gave Mayo some money so that I would be able to put together a video on CAS specific to parents. Oh. So we did it in a question answer format, just as if I was talking to the parent in my office. Mm-hmm. And there are links to that through the Mayo YouTube, and it might just be on regular YouTube too. I'm not sure, but I have those links that I can send you that you can post for parents. And also for parents, the Apraxia Kids website, apraxiakids.org, has information for parents as well.
Okay, awesome. Well, gosh, Dr. Strand, this was just absolutely amazing. It was so fun to connect with you and just hear about all the amazing treatment and research and everything that you've contributed to the field and helped so many people. So thanks so much for coming on. And thanks so much, everybody, for listening. This has been such a great podcast episode. Make sure that you subscribe to the podcast so you don't miss anything great. You never know who we're going to have on, and write a review, because I always love hearing from you. Thanks so much, Dr. Strand, for coming on. It's great to see you.
Thanks for having me.
Bye. Bye-bye. Thanks for listening to Autism Outreach. If you enjoyed the show today, make sure to subscribe so you don't miss an episode full of actionable strategies you can use in your therapy room. Write a review too. That would mean so much to me. I always love hearing from you. Have a specific topic that you want included on a future show? Reach out over on Instagram, ABA Speech by Rose, or visit me at www.abaspeech.org.